Okay, Yashoda, you are good to
Yes,
go.
we can start.
Okay. Good evening. I'm Yashoda, the postgraduate, third year postgraduate from the Department of General Medicine, Coimbatore Medical College. Good evening, Professor, General Medicine, Shivakumar sir, and good evening, Head of the Department,
Hello.
Department
Sir.
of Cardiology, Nambirajan sir, and good evening all the API dignitaries, and good evening all the postgraduates. Today I'm going to present a case. A 14-year boy who hails from Peru came with the chief complaints of palpitations in 6 months, breathing difficulty since palpitations since 9 months, breathing difficulties in 6 months, and fever since 10 days, and multiple joint pains for 8 days. History of presenting illness. Patient was apparently asymptomatic 9 months ago. Then he developed the palpitations, which was gradual in onset, on and off, lasting for 5 to 10 minutes, regular in nature, not associated with syncope, chest pain, polyuria, aggravated with exertion, and relieved with rest. Patient also had a complaints of breathing difficulty since 6 months, which was progressive in nature. Initially, he felt difficulty in climbing the stairs. Now he couldn't able to walk for about 200 meters since last 10 days. The dyspnea has been progressed from NIHA class 2 to class 3 over a period of 6 months. The dyspnea aggravates with activity and relieves with rest. The dyspnea is not associated with orthopnea or PND. Patient had complaints of fever, which was low grade, intermittent, not associated with chills and rigors, no diurnal variation. The history of pain and 8 days back, followed by right knee since 5 days. Pain was so severe, it limited his activities. He is confined to the home and he couldn't able to attend his daily activities like school going since last 8 days. The pain relieved with medication, no other joints are involved. The history of sore throat present 20 days back for 3 years, swelling of the legs, no history of facial puffiness, no history of abdominal distension, no history of involuntary movements, no history of skin manifestations like rashes and nodules, no history of cyanotic episodes, no history of recurrent respiratory tract infections, no history of loss of consciousness, no history of hemoptysis or hematuria, no history of hoarseness of voice, no history of loss of appetite and weight.
Okay, Yashoda, you have enlisted the complaints in history of present illness, and one of the chief complaint is palpitation.
Yes, sir.
So, what are the cardiac causes of palpitation and the non-cardiac causes of palpitation?
Sir, the increased cardiac output conditions like mitral regurgitation, tricuspid regurgitation and aortic regurgitation, and cyanotic heart diseases like Epstein's anomaly and TAPVC, and acyanotic heart diseases like VSD, ASD, and non-cardiac situations like anemia, fever, thyrotoxicosis will present with palpitations.
Would you tell me what is the definition of palpitation?
Sir, unpleasant full awareness of one's own heartbeat, sir.
Yeah, you can you almost you told all the causes of palpitation, but you need to classify into the
arrhythmogenic and non-arrhythmogenic.
Yeah. First, you need to classify into whether it is due to a change in the rate, or change in rhythm, or change in force of contraction. So, change in the rate could be either it could be due to a bradycardia or a tachycardia. Okay. Change in rhythm, it could be an arrhythmias, whether it is an or non-arrhythmic. Okay.
SVT.
Yeah.
Okay, sir.
So arrhythmias, you need to be very clear in telling whether it is a regular or irregular. Okay. Irregular, it could be an atrial fibrillation. Commonest cause of atrial fibrillation, valvular heart disease is
mitral stenosis.
Mitral stenosis. Okay. Then it can be associated with other arrhythmias like your ventricular tachycardia in DCM, or SVTs and other causes. Okay. This is how you should go. And in palpitation, what are the things you will be commonly asking for palpitation?
Sir, whether the rate is regular or irregular, whether it is associated with any syncopal attacks or associated with chest pain or associated with dyspnea.
Okay, what are the common conditions in cardiovascular system associated with the, apart from your arrhythmias and other things, when you mean palpitation in a valvular heart disease, what does it imply to you?
Sir, left ventricular, any ventricular hypertrophy or atrial hypertrophy, sir.
Yeah, you mean to say it is a volume overload status. Already
Yes,
you
sir.
said it is a volume overload status, like your aortic regurgitation or any regurgitation for that matter. It could be a aortic regurgitation or a mitral regurgitation or any volume overload status like your shunt lesions like your VSD.
VSD,
Yeah, VSD, PDA, and
PDA.
others. Okay, to proceed. So whether this was a yeah.
Yes, sir. You want to say, sir?
No, nothing, sir, nothing.
So, what are the non-cardiac causes of palpitation, ma'am?
Sir, anemia, fever, thyrotoxicosis, and drugs and caffeine, alcohol.
Okay. Names. Can you name some drugs which cause palpitation? Commonly used.
Sir, atropine.
Commonly used.
And
Bronchodilators.
Darifilin, sir.
Salbutamol.
Bronchodilators.
Salbutamol, Darifilin.
Okay. Okay, ma. Proceed.
Doctor, does atropine cause tachycardia?
No, sir. In bradycardias, it will increase the heart rate. Sir. We'll be using it for in a bradycardia to increase the heart rate, sir. Can I proceed, sir?
Yeah, you can proceed, ma'am.
So, past history, patient was diagnosed as a case of heart disease at the age of 9 years and he was advised to take monthly injections. Patient was not a known case of systemic hypertension, diabetes mellitus, seizure disorder, tuberculosis or thyroid disorder. Family history, no similar history in the family. Drug history, patient was taking monthly injections till the last 3 months. Then he stopped taking the injections. Then personal history, patient takes mixed diet, sleep is adequate, normal appetite, bowel and bladder habits are normal, not a smoker and alcoholic. Summary. A 14-year-old boy diagnosed as a cardiac illness in the past at the age of 19 years on irregular medication, presented with the chief complaints of palpitation since 9 months, breathing difficulty since 6 months, which was progressive in nature, progressed from NIHA class 2 to class 3, associated with sore throat, fever, asymmetrical migratory polyarthritis for a duration of 10 days. The possible system involved would be a cardiovascular system. The probable diagnosis will be acute rheumatic fever with possibility in the background of rheumatic heart disease. Other conditions like VSD also present with breathing difficulty and palpitations, but the complaints of chest, migratory polyarthritis fever.
What is the commonest cause of breathing difficulty? You said breathlessness, class 2. How do you grade breathlessness? Which is the classification normally you use for?
Sir, NIHA classification, sir.
Okay.
The class 1 includes no restriction of physical activity. Class 2 is a mild restriction of physical activity. Class 3, moderate restriction of physical activity, and class 4, he cannot able to perform any physical activity, sir. In class 2, patient will be performing. Patient will be having difficulty in performing some of the outdoor activities and sports like exertional activities.
Yeah.
In a grade 3, patient will be having a difficulty in performing indoor activities, and grade 4, patient will be having a breathing dyspnea at rest.
Yeah, you're correct. How will you differentiate between cardiac cause of dyspnea and respiratory cause of dyspnea?
Sir, associated with paroxysmal nocturnal dyspnea is one of the feature which is favoring cardiac disease. Sir. Orthopnea may be present in cardiac or non-cardiac illnesses. Sir.
Respiratory will have seasonal variations, okay, and the cough
Okay,
might
sir.
proceed like that. So when you come to dyspnea in cardiovascular system, what does it imply? Which is the system mainly involved? Which is the side of the heart is involved? What is the main?
The left side of the heart, and it indicates increase in the pressure, pulmonary hypertension. Sir.
So it could be due to rise in left atrial pressure and causing pulmonary venous hypertension. That is one cause. Okay, in this case, would you like to relate your dyspnea and palpitation? And with the history, can you come to a conclusion which is the side of the heart is involved, and probably which side is involved, and probably which area, which whether it is a stenotic or regurgitation, which you are going to further evaluate?
Sir, patient does not patient have complaints of dyspnea and palpitation, sir. So I think more in favor of left side heart disease, sir. There is no history of pedal edema, abdominal distension, facial puffiness. So the right side heart involvement will be less likely, sir. Then
So,
patient is
left-sided inflow lesion or outflow lesion? Since
sir,
there is no
palpitations are more
angina and
associated.
syncope, and it could be an inflow, left-sided inflow lesion, probably a regurgitant lesion with the palpitation and a dyspnea. Okay.
Okay.
Right, you proceed.
On general
what are the conditions which will mimic paroxysmal nocturnal dyspnea?
sir,
Conditions
pulmonary
which
edema.
mimic.
Sir,
Patient goes to
paroxysmal.
sleep normally. After a few hours of sleep, he wakes up with dyspnea.
The
So that is
bronchial
paroxysmal.
in the early
Bronchial.
morning, they are presenting with fever, sir.
Okay.
Then paroxysmal arterial tachycardias may cause breathing difficulty, and they may present with palpitations, and it may mimic paroxysmal nocturnal dyspnea. Sir.
Okay, and to some extent, hypoglycemia and panic attacks also can mimic paroxysmal nocturnal dyspnea.
Okay, sir.
And so, what's your diagnosis? With your summary, can you come to a diagnosis?
Sir, patient is having a asymmetrical migratory polyarthritis, sir, which is in favor of rheumatic fever. As a patient was diagnosed as a case of heart disease at the age of 9 years, as the India is more prone for rheumatic heart disease, I think it as a case of rheumatic heart disease with the recurrence of rheumatic fever, sir, involving left side of the heart, sir, as patient is having a dyspnea and palpitations.
So
And
5 years back, he gives a history of rheumatic fever 5 years back, for which he was suggested penicillin prophylaxis. And
yes, sir.
was he not started on any other cardiac drug? Did he go for any cardiac lesion then, or he was just started on penicillin prophylaxis? Was there any other drugs, cardiac drugs?
Sir, we couldn't able to get any records of previous history, sir. They told they are taking only monthly injections at nearby GH, sir. So no other drugs they were taking, sir.
What drugs you will have in mind if you want to ask history for this patient specifically?
Sir, any AC inhibitors?
Okay.
Okay, what are the other causes of migratory polyarthritis in this age group, 14 years age group, apart from rheumatic fever?
Sir, inflammatory bowel disease and hypertriglyceridemia, juvenile rheumatoid arthritis, and SLE.
Okay. Any
And
infective cause like Lyme's disease, gonococcal? What is
post-streptococcal.
post-streptococcal reactive arthritis? How does it differ from your rheumatic arthritis?
Sir, it involves a majorly small joints, sir. In a rheumatic fever, it involves a major joints like knee joint, elbow joint, wrist and hip joints. Then patient the incubation period will be lesser. At the onset of the previous illness and the arthritis in the case of a post-streptococcal reactive arthritis is 1 week, sir. In a rheumatic fever, it will be around 2 to 3 weeks, sir. Then patient will be having a nice, good response to the NSAIDs in a case of rheumatic fever, sir.
So response to salicylates will be much better, and within 2 to 3 weeks it will respond if it is a rheumatic etiology. How common is the rheumatic fever without any previous history of rheumatic fever?
So 30% of the patients will be
up to 50% they don't give a history of rheumatic fever. Okay, right.
Okay.
Proceed.
Okay. General examination. Patient was conscious, oriented, thin built, and moderately nourished. Not dyspneic, not tachypneic, febrile. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. No thyromegaly. Patient weight is 30 kgs and height is 125 centimeters. BMI is 19.07 kg per meter square. Belongs to the upper middle class according to the modified Kupusamy scale. The upper segment to the lower segment ratio is 1 and arm span is 0.98. Vital signs. Pulse rate of 105 beats per minute, normal volume with regular rhythm, felt equally in all the palpable peripheral pulses, no radio radial and radio femoral delay. Condition of the vessel wall is normal. The blood pressure in both upper limbs, right and left upper limbs, are 100 by 60 mm of the Hg measured in the supine position. In lower limbs, it is 110 by 70 mm of the Hg. And respiratory rate 18 cycles per minute, abdominothoracic. JVP not elevated, temperature 100.2 Fahrenheit. SpO2 98% in room air.
So in cardiovascular system, how will you associate fever? Fever in cardiovascular system.
So rheumatic fever and infective endocarditis may be associated.
Any other conditions with fever, cardiovascular system?
Lot of patients during the COVID era, they got into trouble with fever, with the depressed myocardial ejection fraction. What do you call it?
The myocarditis.
Myocarditis is so often common nowadays. In the winter season, also a lot of cases are coming. So myocarditis is one possibility. So infective endocarditis, rheumatic fever, and your masses in the cardiac masses. What do you call it? Myxomas. Myxomas also they can present with fever. LA myxoma and the myxomas can present with the long-standing fever. And infiltrative disorders like sarcoidosis, amyloidosis, and they can also present with. Commonest condition is tuberculosis, pericarditis. Tuberculosis causing pericarditis and fever is so common. So that is another thing.
Any protozoal infection, ma? Yes, this is theory.
Commonly asked question in final year.
Trypanosomiasis.
Yeah, okay.
Kala-azar.
Kala.
Okay, move on.
No marker suggestive of congenital heart disease, infective endocarditis, and rheumatic fever.
What are the markers of rheumatic fever?
Sir, subcutaneous nodules and erythema marginatum. Patient will be having a polyarthritis.
What is Janway lesions?
Sir, painless, large nodules present in the palms and soles.
Okay.
It suggestive of infective endocarditis. Sir.
Okay.
The peripheral signs of aortic regurgitation, The Corrigan's pulse, the dancing carotid was noted, and Thorpe sign, the piston shot femoral was present. On inspection, the oral cavity normal, chest wall bilaterally symmetrical, no kyphoscoliosis, trachea in midline, apex visible at left, fifth, and sixth intercostal spaces lateral to the mid-clavicular line, and carotid pulsations are visible, and the pulmonary area, prominent pulsations are visible, and no other visible pulsations. No precordial bulge, no dilated veins and scars. On palpation, tracheal position confirmed to be in midline. Apical impulse felt at left, fifth, and sixth intercostal space, 1 centimeter lateral to the mid-clavicular line, hyperdynamic in nature, associated with thrill. Parasternal heave of grade 2 is sustained, felt in the left lower sternal border. Palpable T2 present. Auscultation, mitral area,
No,
S1, S2.
no. Please stop. Normally in cardiology, we used to combine inspection and palpation. You said apical impulse. Define normal apical impulse. Normal
Sir,
apical
it is
impulse.
so normal apical impulse will be tapping in nature, sir.
Where
Felt in the
will be the location?
sir, fifth intercostal space, 1 centimeter medial to the mid-clavicular line, sir. Occupying only one intercostal space, sir.
Okay, in this, where is the apical impulse?
Sir, it was
Yes.
down and out, sir. Felt in
What do you mean by down and out with the hyperdynamic in nature? What does it tell you?
Sir, sir, regurgitant lesion, sir.
No.
Or
Down,
any hyperdynamic.
down and out implies there is a cardiomegaly. Okay.
Yes, sir.
Okay. Then if it is hyperdynamic, what do you mean by hyperdynamic apical impulse?
Sir, it occupies more than one space, sir. More than 1.5 centimeters of area, sir.
So what does it imply?
It implies a cardiomegaly and a shift of the left ventricular hypertrophy, sir.
Okay. Right, proceed.
Auscultation, the mitral area, S1, S2 heard, S1 soft, a high-pitched, soft-blowing, pansystolic murmur of grade 4 heard with the diaphragm of the stethoscope with the patient in the left lateral position with the breath held in expiration. The murmur radiates to the apex. Tricuspid region, S1, S2 heard, pansystolic murmur heard with the diaphragm of the stethoscope. Patient kept in leaning forward position with the breath held in inspiration. The murmur increases with the intensity with inspiration. In aortic area, S1 audible, S2 muffled, a high-pitched, soft-blowing, early diastolic decrescendo murmur of grade 3, best heard with the diaphragm of the stethoscope, patient leaning forward with the breath held in expiration. The murmur radiates to the apex, best heard in neo-aortic area, which is third intercostal space. In pulmonary area, S1, S2 heard with the loud T2, a crescendo ejection systolic murmur of grade 2, heard with the diaphragm of the stethoscope, patient leaning forward, breath held in inspiration. Other system examination, respiratory system, normal vesicular breath sounds heard, no added sounds.
Okay.
Abdominal examination.
Okay, with the positive findings of your auscultatory findings and the apical impulse, what do you like to tell us? You have
so there is a
impulse down and out, hyperdynamic apical impulse, implying that it is a volume overload status.
Yes,
there is a cardiomegaly and a volume overload status. It could be any regurgitant lesion with pansystolic murmur in the mitral area and the idiom. What is your inference?
Sir, pansystolic murmur in the mitral area is seen in mitral regurgitation, sir.
What are the other kinds of pansystolic murmur in the mitral area?
Sir, VSD and tricuspid regurgitation, sir.
Okay, how will you differentiate between these three?
Sir, VSD is best heard at the parasternal region, sir. which is radiating to the right side, sir. It won't be radiating to the axilla. Then in tricuspid regurgitation, the murmur increases in intensity with the inspiration, sir.
Very good. Okay. So why it is conducted into the axilla?
Sir, the mitral valve leaflet, the posterior mitral valve leaflet, if involvement of posterior leaflet, the murmur will be conducted to the base, sir. Anterior leaflet involvement, the murmur will be conducted to the axilla, sir.
Okay. So if it is a chronic mitral regurgitation, what are the other additional sounds which can be heard to substantiate that it is a chronic MR?
Sir, a patient will be having a S3, sir.
Did you auscultate for S3 in this case?
Yes, sir. S3 was absent, sir.
Okay, right.
Then MDM murmur will be seen, sir, in a severe MR.
Okay, that could be a flow murmur. What is Austin Flint murmur?
Sir, MDM murmur heard at the apex, sir.
Due to?
Seen in aortic regurgitation, sir.
Very good. Yeah, it's a flow murmur heard due to. How will you differentiate between mitral stenosis murmur of MDM and this flow murmur of AR Austin Flint murmur?
Sir, usually MDM murmur of MS is associated with opening snap or pre-systolic accentuation, and it will increases its best heard with the bell of the stethoscope and in a left lateral position, sir. Then it will be heard in expiration, sir. Maximum intensity will be heard in expiration, sir.
Very good.
Flow murmurs, the intensity won't be varying with the position or in expiration or inspiration, sir.
Okay. With these findings, which lesion is dominant, do you think so? The aortic regurgitation or the mitral regurgitation? When you think the aortic regurgitation is, you said about the peripheral signs of aortic regurgitation. What is it due to? What is the mechanism of peripheral signs? What do you call it?
Wide pulse pressure. Due to wide pulse pressure, there will be peripheral signs of AR, sir.
It is due to the diastolic runoff, we say. So, what are among the signs which you said? What are the two important signs to say it is severe, which will determine severity of aortic regurgitation?
Hill sign, sir.
What is
the
sign?
Difference between the systolic blood pressure in the brachial artery and the femoral artery, sir? If it is more than 20, it indicates mild. If it is less than 20, mild, sir. 20 to 40, moderate, sir. Then if it is
40
more
mild,
than 60,
40 to 60 is moderate. More than 60 is
60
high.
is severe, sir.
Apart from that, what is the other sign which is more significant? What is Durose's sign?
Sir, in femoral artery, there is an diastolic murmur which is heard with a blocking of a distal blocking, sir. There will be a diastolic murmur heard, sir, which is called as Burosier's murmur.
Yeah, these two are very important signs among the 10 other signs of acute AR.
Okay, sir.
Yeah.
Sir, with the above findings, I think mitral regurgitation is a predominant lesion, sir, as it is the mitral regurgitation murmur is determined by hyperdynamic nature of the apex and the thrill, the grade 4 pansystolic murmur associated with thrill, which indicates the severity of the murmur.
Yeah, and the other associated sign, skill sign, and other severity of the aortic regurgitation is not so severe. Okay.
Yes,
what will happen with the long-standing aortic regurgitation? So there will be deterioration of the LV function, and in that also you can have the LVS3 and other things. Yeah, you proceed. Any other investigations you have got?
Sir.
Doctor, one second. Sir, can I ask one question, sir?
Sure, sir.
Yeah,
Yes.
What is the patient's pulse volume and blood pressure, doctor? Can you please tell me that?
Sir, patient had a normal volume pulse, sir, with a hyperdynamic nature of apex, sir. As a patient is having a pulmonary hypertension, the volume may vary, sir. It may be low to normal, sir.
Now, when you have a multivalvular problem or that is dual valvular problem of aortic regurgitation and mitral regurgitation, and what's your the blood pressure and pulse pressure?
Sir, blood pressure is 100/60, sir, which indicates a pulse pressure of 40, sir.
40.
Yes, sir.
So in case of now, how do you explain that normal volume pulse in case of
It
coexistence
should
of
have been a
aortic
large
regurgitation?
volume collapsing pulse, sir. It should have been
Yeah.
sometimes they might have missed it with the treatment. She might have felt it could have been a low volume pulse, but with this aortic runoff and a pulse pressure of 40, it should be a collapsing pulse with a large volume, sir.
There's so many findings you are saying more in favor of collapsing and large volume pulse, but you said even beginning you said normal volume. Probably the exam point of view slightly correct your way of mentioning about the pulse one is more safe for you.
Yes, she might have missed it, sir. She
Okay, sir. I'll correct, sir.
Yeah, thank you.
Sir, we proceeded with investigations like a complete blood count and renal function test, liver function test, and serum electrolytes, ASO titers, ESR, and CRP, sir. Then ECG, chest X-ray, echocardiography.
Just show us the ECG. What do you expect in the ECG? You have the ECG?
Yes, sir. Sir, ECG, normal standardization with a heart rate of 100 beats per minute, regular rhythm, normal axis, with no features of LVH, sir. Usually,
LVH with volume overload or pressure overload? What are the classical features of pressure, volume overload? Is this in this ECG? You can see the Q wave, deep Q wave in V5, V6 and ST elevation and V5, V6. Okay.
Okay.
This is typical of volume overload. If you have a pressure overload, the absence of Q wave in V5, V6 and the T wave will be inverted and ST depression will be there in V5, V6. Okay. Next, X-ray. Okay.
Sir, X-ray of chest PA view with a normal rotation and trachea is in the center with a mild.
Normally, we don't expect anything much more than a apparent cardiomegaly. Is this a LV type of apex or RV type? How will you say?
It's a LV type of apex, sir.
Okay. How do you say it is LV type of apex?
Sir, if the angle made by the heart borders and the diaphragm is obtuse, then we'll say it as a LV apex, sir. If it is acute, then we'll consider it as a RV apex, sir.
Okay. Right. Next, you have got an echo.
Sir. Sir, echo suggestive of AML and PML tip thickening and the prolapse of the AML with a diastolic doming of AML, and the PML slightly restricted, which is suggestive of moderate to severe MR, sir. Then moderate AR with a TRPAH of 400, vena contracta of 0.6. No evidence of clot, no evidence of vegetations, and no regional wall motion abnormality. The diagnosis is rheumatic heart disease with moderate to severe AR, moderate to severe MR with a moderate AR with a normal LV function, sir.
Apart from rheumatic heart disease, rheumatic etiology, any other etiology can you suggest in this sort of situation affecting two valves?
Sir, any? Don't know, sir.
Okay, no problem. Next. Just read it because there are other conditions which will mix up and rest conditions, mucopolysaccharidosis, other conditions which will lead on to both your mitral and mixed degeneration, mitral prolapse, and other things. Okay, next. How will you treat this patient medically and surgically? What is your advice for this patient? 14-year-old boy, 14-year-old boy. Medical management, of course, you will be able to tell us. So you're going for a mitral and aortic valve replacement, double valve replacement.
Yes, sir.
What could be what could be the? Did any mention about the cusps of the aortic valve? Did they mention about any bicuspid? What is the natural history of the bicuspid aortic valve?
Sir, it will present as a
Normally, in the 5th or 6th decade, with the severe AR, and
regurgitation, sir.
25% they have
in a long.
In a younger age group, they can have a severe aortic regurgitation. Bicuspid aortic valve is one of the important etiology in this age group. We have heard cases in our department. 14-year younger gentleman, younger boy who had a bicuspid aortic valve with severe aortic regurgitation, and he underwent aortic valve replacement. Okay, you are going to do a mitral as well as the aortic valve. What is the INR you would like to keep? What is the anticoagulant of choice? Yashoda, are you there? What are the valves? Prosthetic valves?
Around 2.5 to 3.5, sir.
What is the prosthetic valves
sir,
you know? What are the prosthetic valves you know? Metallic valves?
Sir, tilting valve and.
Can we use bioprosthetic valve in this case?
Sir, bioprosthetic valves usually used in females and older age groups, sir. I prefer
in which
mechanical
group,
valves,
if you want to avoid anticoagulants
in
and
this,
there are absolute contraindications for anticoagulant, you can have this. Okay, right. Anything you want to add? What is TAVR?
sir.
TAVR, TAVR. Okay. Sir, Shivkumar, sir.
Yes, sir. Yes, sir. Yashoda, how long will you suggest the patient to take benzathine penicillin? How long will you suggest benzathine penicillin monthly for this patient?
Till, sir, as a
Recommended
patient,
time.
It is recommended for lifelong, sir. According to ACC guidelines, it was guidelines till lifelong. We have to prophylaxis, sir.
Any carditis or valvular involvement does require lifelong penicillin prophylaxis according to the recent guidelines.
Yes.
Okay.
Okay, sir. Saravanan, sir, you have any questions?
No, sir. No, sir. Please proceed.
Okay, sir. So, shall we conclude the session, sir?
Yes, sir. Yes, sir. She has presented very nicely.
Yes,
and,
Yashoda did well.
Almost all the aspects of rheumatic disease involving mitral and aortic. This is the commonest combination which we come across: mitral regurgitation and aortic regurgitation. And being a younger boy, we can wait till there are. We need to know the class 1 indications for dual valve replacement. We need to assess the LV diastolic and systolic dimensions. If it is more then we can go ahead, because long-standing anticoagulation and further prosthetic valve mismatch could be another issue with the growing child. But nowadays the valves have been advanced to suit the needs. So nice presentation, sir. We can conclude, sir. Shivkumar, sir.
Yes, sir. Yeah, we can conclude the session, sir.
Yes, sir. Right, sir. Thank you, sir. Thank you,
Yes,
sir.
sir. Thank you, sir. Thank you very much, sir.
Thank you, Saran, sir, and others. Thank you, sir.
Thank you. We will go for the next session, sir.
Yes, sir. We'll move to the next session, sir.
Yeah. Thank you, Dr. Yashoda, and I invite Dr. Srinivasan to start presenting. I also welcome and invite Dr. Shadilvadi Madam, Assistant Professor of Department of Gastroenterology of Government College, to join. And I thank and welcome Dr. Shivakumar sir also for this second session of this today's evening. To also be the moderator and faculty for this evening. Over to Srinivasan and Dr. Sandilvadi Madam and Dr. Shivakumar sir to take over.
Hello,
Srinivasan, can you please
Sandhya
go ahead?
madam. Good evening, madam. You are there?
I think she has not joined, sir. It's probably eight,
Oh, she is not
9:30.
there.
Dr. Srinivasan, can you please call Madam to join? Dr. Srinivasan? Dr. Srinivasan, unmute yourself.
Yes, sir. I unmuted, sir.
Yeah, just talk to Madam and try to ask her to join the meeting.
Okay, sir. Ma'am, group meeting started, ma'am. Okay, ma'am. Participants list காமிக்கல, ma'am. Yes, ma'am. Okay, ma'am. Video play ஆயிடுச்சா, ma'am? Okay, ma'am. Yes, ma'am. 6 participants இருக்காங்க, ma'am. But உங்க number participants இல்ல, ma'am. Second join send பண்ண இதுதானா, ma'am? Ma'am, one minute, ma'am. மேம் லாஸ்ட்ல ஒரு லிங்க் எஸ் மேம் ஜாயின் மீட்டிங் ஐடி அண்ட் பாஸ்வேர்டோட இருக்குல்ல மேம் அந்த Zoom meeting. Again I will send the message to send பண்ணிட்டேன் மேம். இல்ல மேம் செகண்ட் கடைசியா அனுப்புனது மேம். இப்போ அது ஃபார் அது பார்க்க
Hello. Srinivasan.
Hello, madam. You have joined, madam.
Yes, she has joined, sir, but she has not connected through her audio. Only video is connected.
Oh, oh, oh.
She has to connect through the audio also.
Okay, sir. Connecting to audio வருது.
Probably she has joined through two devices. It's going to disturb her audio and video also. You got two names of her list of participants. Okay, now she's joined through only one device, but she has to join through the audio also.
Yes, sir. I can see that.
Yeah. Srinivasan, can you please help madam to join through audio also? Srinivasan, please unmute yourself.
Yes, sir.
Can you please help madam to join through her audio also? I think she has joined, but she has joined through only the video, not the audio.
Yes, sir. Within 1 minute, ma'am is coming through the online, sir.
Once again, she is joined back, but only through video, not through audio.
Ma'am. Okay. Okay. Hello, ma'am. Ma'am, video வந்திருக்கு ma'am, but audio connect ஆகல ma'am. Yes, ma'am. அந்த ஆப்ஷன்ஸ்ல mute, start audio, share, participants, more இருக்கு ma'am. அதுல அந்த
Hello, madam. Have you joined, madam?
Yes, she has joined now. She's connected through audio also. She has to unmute, sir.
Right. Yeah, I think so, sir. Good evening, madam. Welcome, madam.
Madam, please unmute yourself, madam.
Yes, sir.
Yes, madam. Good evening, madam. Good evening.
Good
Welcome.
evening, sir. Yes.
Yeah.
Good evening,
Okay,
madam.
we'll start the session. Okay,
Srinivasan, can please
Srinivas.
share your screen? Yeah. Srinivasan,
Sir,
share your screen, please.
sir, it is telling you cannot start your video because the host has disabled it, sir.
Okay, one second. One second. One second. One second. No,
Thank you, sir.
yes. Correct. Yeah. You can see the green icon downstairs. Just click on it. Connect through your screen.
Okay, sir.
Dr. Srinivasan, were you able to locate the icon for sharing your slides?
Yes, sir.
Please connect through the sharing your screen.
Okay, sir.
But don't connect through two devices, Srinivasan.
1 minute, sir.
Yeah, you will get the echo. Yeah, this is a problem. Don't connect through two devices. You will get the echo. Only one device you have to connect through.
Okay, sir.
Yes. Only one is to be there. Then connect through your icon. Click on the icon for sharing your screen. Green color. You'll be asked to select the slide area. Go to the area and select your slides. Were you able to locate Dr. Srinivasan? Dr. Srinivasan, are you there? Unmute yourself.
Sir, is it that Yashoda is also a co-host? Is not able to upload, sir?
No, she already finished now, sir.
Yeah, she has finished, but it shows that she is also a co-host. Yashoda.
Probably she's continuing with the presentations. The forum she might be continuing, sir.
Okay, sir. So we should ask her to.
No, not necessarily the being a co-host or a simple presenter doesn't matter, but
Okay.
the presenter should be able to, because whoever is connected through this platform should be able to share their screen. And
Okay.
she is the presenter, and Yashoda has come out of the presentation. Anybody else can join through the sharing the screen. You should be able to locate that part of sharing the screen. That icon he has to pick up. Click on it. You will ask him. It will ask him to show the slide where it has to be picked up.
Okay. Srinivasan, and the green color இருக்கல்ல share screen.
ஒரு arrow
Srinivasan,
mark போட்டு ஷேர்னு போட்டிருக்கும் பாருங்க. ஒரு அன்மியூட்லயே இருக்காரு. மீன்ஸ் மியூட்லயே இருக்காரு. He is not unmuting.
Yashoda, I don't have his number. Can you call and tell him?
Okay, sir. I'll call him and
You call and tell Srinivasan to share screen. அந்த share screen optionல போய் upload பண்ண சொல்லுமா, அதுக்கு வர சொல்லு.
Okay, sir.
தம்பி ஏதோ ஷேர் ஸ்கிரீன் ஆப்ஷன்ல போய் உன்னை பண்ண சொல்றாங்க தம்பி. ம் ம் ஓகே, பொறுமையா பண்ணுங்க, நிதானமா பண்ணுங்க.
But Srinivasan, what is the practical difficulty you're experiencing? Is not unmuting, and you don't know what is the exact practical difficulties experiencing.
Sir, 2 minutes, sir. Come back to the online, sir. I am difficult in uploading the PowerPoint presentation, sir.
What happened? You should be having your desktop, right?
Yes,
Or
sir.
in your mobile. Okay. And just click on the share. It will ask you where to choose the slides or which content to be shared. You try to
Okay,
select
sir.
that. First, you click on the share part, the icon, share icon. Able to locate the share icon?
Yes, sir. Yes, sir.
Click on it. It will ask you which one to be selected.
Okay, sir.
Where is the location of your slides? You try to choose that. And double click, it will start to open up.
Okay, sir.
You're using your mobile or using your laptop?
Sir, I am using my mobile, sir.
Mobile. Okay. You should be having the location of your PowerPoint, right?
Yes,
Is it
sir.
in downloads or anywhere else or in your file?
It is in my file, sir.
File. Okay.
But
Try to first select the share. It will ask you which
okay,
one
sir.
to be selected. You have to choose whether to choose the download or choose the files. You try to select the
Okay, sir.
first file. From there, you try to select the area of your replacement of your slides in the files folder.
Okay, sir.
You're using iPhone or Android?
I am using Android phone, sir.
Android. Should be easy then.
Yes, sir. Uh,
Don't be nervous. Make it. Or any friends are there, ask them to help you out.
yes, sir. I asked, sir.
Okay, okay. Okay, while waiting for the Srinivasan to upload, Sir Shivkumar sir, can we have some discussion with since Yashoda is there? We'll catch hold of her and we'll ask some questions about the abdomen case.
Okay, sir. Sure, we'll do
Yeah,
that. And
because some difficulty for Srinivasan. Just wait for him to
okay,
join. He sought for some friends' help also. Let them come and do it. While waiting
yes,
for a long time, we'll just discuss some points related to abdomen. Is it okay, Siddhan? What do you, madam?
Yes, sir.
Yeah. Not Yashoda, are you there?
Yashoda, are you there?
Yes, she's there. She has to unmute her.
Yes, sir.
Okay, just
Sir, can I
assume
share his presentation, sir?
you saved the presentation.
Sir, I have his presentation, sir. Can I display in my
Yeah,
thing and
sure.
can I
Sure.
help him, sir?
Yeah, please go ahead. Please go ahead.
Sir, 1 minute, sir.
Yeah, then you have to ask Srinivasan to not to share the icon of share. We have to show that. Now, Srinivasan stop sharing. Let us share the slides.
Okay, sir.
Okay, sir.
Srinivasan is disconnected.
Sir, can you able to see?
Yeah, you should be. You should be, doctor. No issues at all. Yeah, start sharing and start your videos. Srinivasan just now joined back. Were you able to join or means to
Hello,
connect
sir.
through? Not able to share your slides?
Sir?
Srinivasan's screen is sharing now, sir.
Oh, if you're
Sir,
sharing, that means, yeah, correct.
I think we'll let Srinivasan proceed, sir.
Yeah, please.
Okay.
Srinivasan,
Yes, sir.
we are
Sorry
able to
for
view your
the
screen.
interruption,
Yeah.
sir. I have
No,
some trouble on the phone,
no
sir.
problem. No problem. Concentrate on
That's
the
when
presentation. Start presenting. No issues.
Okay, sir. Good evening, sir. Good evening, ma'am.
Good evening.
My topic is a case of massive splenomegaly. Chief complaints, Mr. Jadayan, 63-year-old male who was security worker by occupation with complaints of abdominal distension, loss of appetite, loss of weight for the past 2 months. History of presenting complaints. Patient presented with complaints of abdominal distension for past 2 months, which was gradual in onset, progressive in nature, localized to the left upper quadrant, associated with early satiety and discomfort. Chief complaints of loss of weight for past 3 months, weight reduced around 7 kgs in the last 3 months in the form of loosening of clots noted by the patient's attenders. History of loss of appetite present for the past 3 months. History of easy fatigability present. History of palpitations present, which occurs during exertion, which is rapid in nature and terminates spontaneously within minutes, not associated with any syncopal attacks. Not associated with any syncopal attacks. The palpitations are 2 to 3 episodes per week for the past 1 year. History of exertional dyspnea present for past 1 year, not associated with ortho.
audio வரலப்பா.
No history of, sir.
Srinivasan,
Srinivasan,
continue.
you just in between your audio. Just once again presentation.
Okay, sir. No history of melena and other bleeding manifestations. No history of difficulty in swallowing. No history of nausea. No history of yellowish discoloration of eyes and urine. No history of altered bowel habits. No history of fever. Past history. Patient is not a known case of systemic hypertension, type 2 diabetes mellitus, coronary artery disease, CKD, CCF, liver disease, tuberculosis. No history of any previous surgeries. No history of any drug intake in the past. Personal history. Patient consumes mixed diet, non-smoker, alcoholic for the past 10 years, who consumes around 90 ml per month, normal sleep pattern, normal bowel and bladder habits, no significant family and treatment history. Summary, a 63-year-old male, alcoholic with no other comorbidities, now complains of localized abdominal distension with early satiety, loss of appetite and weight for past 2 months, with easy fatigability and exertional dyspnea and paroxysmal palpitations for past 1 year. Abdominal distension for evaluation.
Okay.
So with this
Srini,
summary, what is your impression?
Sir, a patient is having left localized distension with the early satiety, sir. It indicates the patient may be having any enlargement of the spleen, sir, with the loss of appetite and a loss of weight, which points towards malignancy with easy fatigability, exertional dyspnea, and paroxysmal palpitations towards anemic symptoms, sir. So, patient is having anemia with weight loss, loss of appetite, with the mass in the abdomen, sir.
hello.
Ma'am,
Yes, madam, you're audible.
Yes. The mass is from left upper quadrant.
yes, ma'am. Yes, ma'am.
The swelling is from left upper quadrant with early satiety, loss of weight, loss of appetite, easy fatigability. Okay.
Yes, ma'am.
What could be the mass? From which organ?
Ma'am, probably it will be from the spleen, ma'am.
Okay.
Because whenever the patient is having the left upper quadrant mass, and the patient is also telling the history of early satiety, ma'am. The enlarged spleen, which compresses the fundus, ma'am, maybe fundus of the stomach, so it causes the early satiety, ma'am.
Okay. Then
And the patient is also having the easy fatigability, exertional dyspnea, and palpitations, which is paroxysmal in nature, ma'am. which accounts for the anemia. Maybe the spleen, whenever the spleen is enlarged, it causes the anemia, ma'am. Hypersplenism, anemias and cytopenias. That may cause the easy fatigability, dyspnea, and palpitations, ma'am.
Okay. How do you attribute to his dyspnea? Paroxysmal dyspnea.
Patient is having dyspnea only at the exertion, ma'am. In anemia, during exertion, tachycardia will be there. During tachycardia, there will be a myocardial oxygen supply and demand mismatch, ma'am. At that time, patient will be having the dyspnea, ma'am.
Okay. Any other differential you want to tell, or any other mass from left upper quadrant? What are the other masses that could be from left upper quadrant?
Sometimes a left renal mass will be there, ma'am.
Okay, renal mass can
Yes,
be
ma'am.
present. Is the patient is having fever?
No, ma'am. No fever, ma'am.
Okay, renal mass, then spleen, then other masses from left hypochondrium. What are the other masses?
Sometimes any retroperitoneal mass will be there, ma'am, in the left upper quadrant, which will be causes the symptoms of this patient, ma'am.
Retroperitoneal mass. Okay.
Yes, ma'am.
What are the organs that is seen in the left hypochondrium and epigastrium? What are the masses?
Ma'am,
Only spleen and the kidney?
no, ma'am. Spleen, kidney, stomach, ma'am. Stomach, mainly fundus of the stomach, and
Good.
the tail of the pancreas, ma'am.
Okay.
Left lobe of liver will be there, ma'am.
Okay, when it is enlarged. Next.
These 5 organs will be there, ma'am.
Okay, splenic texture can also be there.
Okay, ma'am. Okay, ma'am.
Then, do you want any other differential either from this splenic mass? Do you think other masses can produce all these symptoms?
No, ma'am. Other mass will cause a left localized distension with the with early satiety, but the patient here is having prominently anemic symptoms, ma'am. So anemia attributable to the spleen, ma'am.
See, even if the patient is having any gastric malignancy, he can have distension, early satiety, anemia, easy fatigability. Left colon splenic mass can also be there. Passive malignancy of pancreas can also present like this. Okay,
ma'am.
you should have all differentials.
Okay, ma'am.
Yes, proceed.
Thank you, ma'am. General examination. On examination, patient is conscious, cooperative, afebrile, pallor present, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, and no pedal edema. No markers of liver cell failure, no markers of TB, no markers of malignancy, no sternal tenderness. Vital signs.
Why do you want to see for markers of TB here?
Ma'am, any abdominal tuberculosis is a great massacre, ma'am. It will be occur in the any form, ma'am. Sometimes primary peritoneal carcinomatosis or TB abdomen, it will cause the anemia with loss of weight and loss of appetite. So I consider TB as one of the possibilities, ma'am.
Peritoneal involvement will present like this?
No, ma'am. Peritoneal involvement will cause generalized abdominal distension with anemia, ma'am.
Okay, lymphadenopathy. Okay.
ma'am.
Then markers of what next is? Markers of
HIV, ma'am.
Okay, then markers of malignancy. What are the other cutaneous markers of malignancy? What are the markers you have seen in this patient?
Ma'am, I have seen for a generalized tinea versicolor, ma'am.
Okay.
Generalized tinea versicolor, any matted lymph nodes, any discharging painless sinuses, ma'am. Sinuses. These
What
are
do
the
they
things.
indicate? What do they indicate? You are telling that markers of malignancy. What are the markers?
Lymph nodes, ma'am. Painless, palpable, painless lymph nodes, ma'am.
Okay.
I searched for the lymph nodes, ma'am.
Okay.
For
What is
example,
the consistency you want in that lymph node?
Ma'am, it is firm to hard in consistency, ma'am, in malignancy.
Okay.
And it is a non-palpable in malignancy, ma'am. So, sorry, ma'am, it is a painless in malignancy, ma'am.
What is it called? Rubbery consistency in which?
Ma'am, rubbery consistency in Hodgkin's lymphoma, ma'am.
Okay. Then for lymph nodes, mated lymph nodes, sinuses, you want to see. You are
Yes,
telling
ma'am.
that
Mated sinuses
one
and
of
lymph
the
nodes are seen in tuberculosis, ma'am.
cutaneous markers of malignancy.
Cutaneous markers of malignancy, one is generalized tinea versicolor, ma'am. And
Okay.
okay, ma'am. And another one is uh, reddish skin eruptions like Kaposi sarcoma, ma'am.
Okay, continue, Srinivasan.
Okay, ma'am. Thank you, ma'am. Vital signs: pulse rate 82 per minute, normal in rhythm and volume, no specific character, no radial and radiofemoral delay, felt equally in all the palpable peripheral vessels. Blood pressure 170 millimeters of mercury in right upper arm in sitting posture. Respiratory rate 18 per minute, regular abdominothoracic type with no usage of accessory muscles. Temperature 98.4 degree Fahrenheit, JOP not raised, BMI 18.36.
What do you expect in pulse in this patient?
Pulse will be in the tachycardic side, ma'am, more than 100, ma'am.
But this year it is?
82, ma'am. Now, patient not in tachycardia, ma'am.
Okay.
Okay, ma'am. Systemic examination, abdominal examination, inspection, skin over the abdomen normal, localized distension seen in the left hypochondrium, umbilicus in midline, inverted, no nodule seen, decreased movement on the left upper quadrant, no visible pulsations, no visible peristalsis, no visible scars and sinuses, no divarication of recti, no dilated veins, no supraclavicular fullness, flanks are free, external genitalia normal, hernial orifices free.
Okay.
Okay, ma'am. Palpation, superficial palpation, no warmth, no tenderness, deep palpation, lower border of the liver not palpable, spleen palpable from 3 centimeter below umbilicus, splenic notch felt on the inferior medial border, smooth surface, which is feminine consistency, non-tender, moves with respiration, and non-palatable, not bimanually palpable, ma'am.
Okay.
Xiphi sternum to the umbilicus 18 centimeter, umbilicus to pubic symphysis 11 centimeter, ratio 1.6, left anterior superior iliac spine to umbilicus 19.5 centimeter, right anterior superior iliac spine to umbilicus 18 centimeter, no inguinal, para-aortic, mesenteric or other lymph nodes not palpable, external genitalia and scrotum normal, hernial orifices free, abdominal girth 85 centimeter.
Okay.
Okay, ma'am. Percussion, liver dullness starts at right fifth intercostal space at midclavicular line, measuring around 10.5 centimeter. A drop space is a dull on percussion, obliterated, no shifting dullness, no fluid thrill, ma'am.
Okay. In inspection, you told that there is no nodule in the umbilicus. What nodule you expect?
Ma'am, sometimes in GI malignancy, there is a Sister Mary Joseph nodule, ma'am, around the umbilicus. So I searched for that node, ma'am,
Okay.
which indicates the underlying primary GI malignancy, ma'am.
Okay. Okay. You mean to say that it is splenomegaly?
Yes, ma'am.
How will you palpate for spleen? What are the other
Totally.
methods?
Okay, ma'am. First one is classical method, ma'am. In the classical method, we should start palpating from the start palpation from the right iliac fossa, and during expiration, we should move the hand over 1 centimeter towards the uh, left hypochondrial region, ma'am.
Yeah.
Then next one is hooking method, ma'am. If the spleen is not at all palpable, we should insinuate the fingers between the left costal margin using the right hand In the meantime, our left hand should be over the behind the left costal margin, ma'am.
Okay, ask the patient to
Ask the patient to turn towards the right side, ma'am. Right lateral decubitus position, ma'am.
okay.
And in a Middleton maneuver, ma'am, we have to ask the patient to make the fist, and we have to ask the patient to go to make the fist and put that fisted hand over the left inferior angle of the scapula, ma'am. Then in ascites, we should palpate by the dipping method, ma'am.
Okay. So you mean to say this is spleen?
Yes, ma'am.
Okay. Why do you say it is spleen?
Ma'am, spleen, it enlarges towards the right iliac fossa, ma'am. The other masses from the left hypochondrium is left renal mass, ma'am. The difference between the spleen and renal mass is spleen moves towards the right iliac fossa, and the spleen is moves with respiration. Spleen is not palatable. Spleen is not bimanually palpable, and the edges are sharp in the spleen, whereas in kidney the edges are smooth and rounded in shape, ma'am.
Okay.
And in spleen there is a notch, ma'am. In inferior medial border there is a notch will be present, but in renal kidney there is no notch in the kidney, ma'am.
Okay, Srini, proceed.
Thank you, sir. Auscultation, bowel sounds here.
In case
No
of
renal.
kidney, it will be resonant because the bowels will be overlying the renal mass.
Yes, ma'am. Colonic band of resonance will be present in the kidney, but in the spleen it will be absent, ma'am.
Absent. Okay.
Yes, ma'am.
So
Okay,
by
ma'am.
palpation, you confirmed it. It is to be a splenic mass, spleen enlargement, whether it is mild, moderate, or
Severe, ma'am.
massive, severe. How?
If the spleen is enlarged up to 3 centimeter below the costal margin, it is mild, ma'am. 3 to 7 centimeter, it is moderate. If it is more than 8 centimeter below the left costal margin, it is a massive splenomegaly, ma'am.
Okay. What are the other percussion methods?
Ma'am, percussion methods, there are three percussion methods, ma'am. One is Castell's method of percussion, ma'am. Along the anterior axillary line in the left costal margin, usually the 8th or 9th intercostal space, last intercostal space, ma'am. In normal persons, during both inspiration and expiration, the Castell's point is resonant. In mild splenomegaly, during inspiration, the Castell's point is dull. During expiration, it is resonant. In moderate to massive splenomegaly, both inspiration and expiration, there is a dullness noted, ma'am. Another method of percussion is Nixon's method, ma'am. Patient has to be put in the right lateral decubitus position, and at the midpoint of the left costal margin, perpendicular to the axis, we should percuss, ma'am. After 8 centimeter from the midpoint of the left costal margin, usually there is a resonant note, but in the splenomegaly, even after the 8 centimeters from the midpoint of the left costal margin, there is a dullness noted, ma'am.
Okay, what
And
is drop space percussion called?
Okay, in a drop space, the boundaries are above sixth rib, laterally by the anterior axillary line, below the left costal margin, ma'am. Usually, the content of the drop space is fundus of the stomach, ma'am. Usually, it is a tympanic in the note, ma'am. In splenomegaly, it is a dull note at the drop space will be noted, ma'am.
Okay. In case of splenic enlargement and the stomach also, it will be obliterated.
Obliterated. Okay, ma'am.
Right. Okay, continue.
Other system examination, CVS S1, S2, heard no murmur or respiratory system, bilateral normal vesicular blood sounds present, no added sounds. Central nervous system, no focal neurological deficit. Patient moves all the four limbs. Fundus examination, normal, ma'am.
What do you
Srinivasan,
want to see?
what is splenic rub? Where will you look for it, and which conditions? Why do you get that?
Sir, if any infection or a thrombus sepsis which causes the enlargement of the spleen, there is a splenic rub, sir.
Due to multiple splenic infarcts.
Yes, sir.
Okay. Resulting in perisplenitis. So you will be able to hear a rub.
Rub, okay, sir.
Okay, in which conditions you get that? Name some conditions where you, which can result in perisplenitis, and you can hear a splenic rub.
Okay. Splenic abscess, sir. Infective endocarditis, sir.
In CML and sickle cell anemia,
Anemia.
you can get splenic infarcts.
Okay, sir.
What is the consistency of spleen here?
Ma'am, here the consistency of spleen is firm consistency, ma'am.
Okay, where do you get soft spleen?
Ma'am, usually the spleen is soft. The basic the spleen is soft, ma'am. In malignancies, we will get the firm to hardened consistency spleen, ma'am.
Okay. Where you will get tender splenomegaly.
Ma'am, in infective endocarditis, we will get a tender splenomegaly, ma'am, and splenic abscess, there is a tender splenomegaly, ma'am.
Okay. In malaria and enteric fever?
In enteric fever and malaria, it is also tender, ma'am, tender splenomegaly, ma'am.
In malaria, you will have tender, huh? Okay, continue. What do you want to see in cardiovascular system here?
In cardiovascular system, any changing in the murmur, ma'am, and any functional hemic murmur, we have to see, ma'am.
Okay.
And
What
there
is
is a
CNS
cervical,
examination?
ma'am.
CNS examination?
CNS examination, we should check for the fundus examination, ma'am, to look for any rod spots.
No, what you have written in this CNS examination?
Ma'am, no focal neurological deficit, ma'am. Patient is moving all the four limbs. Bilateral
What
pupil.
deficit? What deficit do you expect here?
Any for focal neurological deficit, like if the patient is having a splenomegaly and if it is due to malignancy and the primary is somewhere else, which metastasis to the CNS, sometimes it causes the focal neurological deficit in the form of weakness, hemiparesis, man.
What malignancy you want to diagnose from this spleen and with this finding? What do you think? What malignancy you would think?
Mostly gastric malignancies, ma'am. Gastric malignancies metastasis to the CNS, ma'am, central nervous system, which causes hemiparesis, ma'am.
No, doctor. In this case, you are telling that it is only a splenomegaly with no lymph nodes, no other mass. This is absolutely a splenomegaly. With this, what malignancy you want to diagnose? What do you
I
think?
know.
What malignancy? Yes, okay, continue.
Okay.
In respiratory system?
Ma'am, respiratory system is here on the normal, ma'am. In anemia, we should check for any consolidative mass present in the uh, uh, lungs, ma'am, especially in the left lower lobe, ma'am, because top space is obliterated. Sometimes any left lower mass in the lungs, which also causes obliteration in the drop space with the anemia, ma'am.
Okay.
So how will you call this spleen? Is it moderate spleen or massive spleen?
Massive spleen, sir. If the
Okay.
spleen is enlarged below the costal margin, less than 3 centimeter, it is a mild splenomegaly, sir. 3 to 7 centimeter moderate, and if it is more than 8 centimeter below the costal margin, it is then it is called as massive splenomegaly, sir.
What are the conditions which produce massive splenomegaly?
Sir, massive splenomegaly is produced by chronic myeloid leukemia, hairy cell leukemia, polycythemia vera, chronic autoimmune hemolytic anemia, and tropical splenomegaly, sir.
So thalassemias.
Thalassemia major, sir.
Okay. So if there is splenomegaly is associated with jaundice, what will you think of?
Sir, the splenomegaly associated with the jaundice, first I will think for any autoimmune hemolytic anemia, sir, and subacute bacterial endocarditis. Then any extrahepatic causes of portal vein obstruction or cirrhosis, which leads to the splenomegaly, sir, with the jaundice.
Splenomegaly with purpura.
Sir, splenomegaly with purpura, it occurs in systemic lupus erythematosus, subacute bacterial endocarditis, and other autoimmune connective tissue disorders like rheumatoid arthritis and sarcoidosis, sir.
What is Feltis syndrome?
Sir, Felty syndrome is rheumatoid arthritis, splenomegaly with neutropenia is called as Felty syndrome, sir.
Okay. So you proceed, Pa.
Then diagnosis is anemia with massive splenomegaly for evaluation, sir.
What is hypersplenism?
Ma'am, hypersplenism, there is a criteria, ma'am. The first point is the spleen will be enlarged, ma'am. Even if it is a mild splenomegaly, it is one of the criteria, ma'am. Then it should cause the cytopenias, ma'am. Cytopenias, and after the removal of the spleen, there is a reversibility of the cytopenias, ma'am.
Okay. What is tropical splenomegaly?
Tropical splenomegaly is most commonly caused by the chronic malaria, ma'am. It is due to the hyperimmune response to the malarial parasites. In that patient, there is a high antibody titer with the low parasitemia, ma'am.
What is the other name for that?
Other name for that is hyper malarial splenomegaly, ma'am.
Okay.
Hyperendemic malarial splenomegaly, ma'am.
Okay. Will it get reversed after management?
Yes, ma'am. Definitely, it will get reversed after management. Example with the chloroquine weekly dose. After giving the chloroquine weekly dose, it will be completely reversible, ma'am.
What percentage and after how many months?
I don't know, ma'am. I will
Okay.
read and.
No problem. Splenomegaly with jaundice, splenomegaly with anemia, splenomegaly with lymphadenopathy. Okay,
Yes,
you have
ma'am.
to know all the differentials.
Okay, ma'am.
Come on, proceed.
Okay, ma'am. Splenomegaly with lymphadenopathy is caused by mainly lymphomas, ma'am. Lymphomas, sarcoidosis, and connective tissue disorders like SLE, ma'am.
Okay. If the patient is having this patient with massive splenomegaly, if he is having fever,
Okay, ma'am.
what do you think of type B symptoms?
Then fever, then I will think of malignancy, ma'am, like chronic myeloid leukemia, because here the patient age is 63, ma'am.
Okay.
So I will think of chronic myeloid leukemia or another leukemias, ma'am, like hairy cell leukemia, another non-Hodgkin's lymphoma, ma'am.
Leukemias, lymphomas.
Lymphomas, ma'am.
Okay. Yes, come on. Your diagnosis is?
Anemia with a massive splenomegaly for evaluation, ma'am.
Okay. How will you proceed?
Okay, ma'am. Then I will proceed with the basic investigations with the CBC, ma'am. RFT, LFT, peripheral smear, urine routine, chest X-ray, USG, abdomen, bone marrow aspiration and biopsy, and colonoscopy, ma'am.
Okay. What do you want to see in CBC?
And
What do you
CBC,
expect?
I want to see the cytopenias, ma'am. Leukopenia, thrombocytopenia, and pancytopenia due to the massive enlargement of the spleen, ma'am. Hypersplenism symptoms I want to see, ma'am.
Okay. What do you don't want to see about hemoglobin status?
Yes, ma'am. I want to know the hemoglobin status and the RBC mass, ma'am, because thalassemia major is also one of the cause for massive splenomegaly, and I would like to see the Menser index, ma'am.
Okay. Then renal functions?
Ma'am, renal functions and mainly liver function test, ma'am. I should check for any indirect hyperbilirubinemia, ma'am. Patient is
What?
clinically not ectric, ma'am, but I want to check whether he is in hemolysis or not, ma'am.
Okay. Then what? What do you want to see in peripheral smear? You need peripheral smear?
Yes, ma'am. Sometimes the blast cells will be seen in peripheral smear itself, ma'am. So I want peripheral smear, ma'am.
Okay. What malarial? Do you want to see malarial parasite?
But yes, ma'am. But mostly the malarial parasites will be negative in the peripheral smear, ma'am. Only the investigation IG antigen will be antibody titer will be present in the tropical splenomegaly, ma'am.
Okay. What do you see in peripheral smear of malaria? How to take a smear? What is QBC?
Quantitative Buffy coat, ma'am. We should take the blood, ma'am. The first one, thick and thin slides, ma'am. We should take the blood and we should smear the blood in the glass slide, ma'am. There is a thick and the thin.
Slides, you have to see all the species. What are the 4 types of species of malarial parasite?
Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malarium. In India, the most common two malarias are Plasmodium vivax and Plasmodium falciparum. In the thick slide, we will see which organism is causing the malaria, and in the thin slide region, we will quantify the amount, ma'am.
What is black water fever?
And black water fever, there is a hemolysis, ma'am, with intravascular hemolysis, which causes a hemoglobinuria, ma'am, and the black is discolorization of the urine with the thrombus risk formation, which causes a cerebral symptom, cerebral malaria and all, ma'am. In black water fever, there is intravascular hemolysis, which causes a hemoglobinuria, so the urine will be dark in color, ma'am.
In which species?
It is seen in falciparum, ma'am.
Okay, which will cause massive splenomegaly and splenic rupture.
Ma'am, Plasmodium vivax and Plasmodium ovale, which causes the massive splenomegaly with the splenic rupture, ma'am.
Mostly ovale.
Ovale.
Okay, which will cause renal problem? Glomerular nephritis.
Nephritis. I don't know, ma'am.
Okay. So, what are the recent methods by which you can diagnose malaria? Other methods.
One is peripheral smear, thick and thin smear, quantitative Buffy coat, ma'am. Buffy coat and IgM antibody titers, ma'am.
Okay. Next one, you want to see blast cells and immature cells in the peripheral smear.
Yes, ma'am.
Okay, you're telling that the patient is anemic. What are the other things you will see in the peripheral smear of anemic patients?
Ma'am, the other things we will look for is anisopoikilocytosis, ma'am. Anisopoikilocytosis, macrocytes, macroovulocytes. These are the other things I will see, ma'am. And the other things in hypersplenism, we should see for whole jelly bodies and Ains bodies, ma'am.
Why?
In hypersplenism, there is a denaturated hemoglobin, ma'am. Denaturated hemoglobin. So it will be seen in the peripheral smear as Haynes bodies with the whole jelly bodies, ma'am.
Okay. Post splenectomy patients, what does the peripheral smear finding?
Post-splenectomy patients will also have that whole jelly bodies and Haynes bodies with a few teardrop cells, ma'am.
Why?
Ma'am, because the old senescent RBC cells are destroyed in the spleen, ma'am, splenic circulation, ma'am. After splenectomy, the old senescent cells will be again circulated into the bloodstream, ma'am. So it will, and the cells are easily fragile. So whenever it enters again into our body after 120 days, the RBCs will shows that whole jelly bodies and Ains bodies, ma'am.
What is tufsin? What is tufsin?
Tuft cells,
Okay.
ma'am.
Tufsin. Okay, peripheral smear findings in lymphomas, leukemias. Then you want to see for reticulocyte count here?
Yes, ma'am. Reticulocyte count usually in malignancies, it is more than 2.5, ma'am.
Okay.
Because of
Okay,
the
come on.
increased destruction and the increased production of the RBCs, there will be an increase in the reticulocyte count more than 2.5, ma'am.
Okay, come on. Proceed.
Okay, ma'am. Then chest X-ray, ma'am. I will check for any cannonball metastasis or any primary malignancies in the X-rays itself, ma'am.
Okay.
Then UST abdomen with pelvis, ma'am. So UST abdomen is the method of choice to determine the actual spleen size, ma'am. Spleen size and any lymphadenopathy, para-aortic lymphadenopathy will be seen in the UST abdomen, ma'am.
Okay.
Okay, ma'am. And the bone marrow aspiration and biopsy, ma'am. The patient is having massive splenomegaly. If we are planning for a splenectomy, means we should check for bone marrow biopsy to look for any bone marrow failure. If the patient is in marrow failure, we should not do splenectomy because spleen is the only source of extramedullary hematopoiesis, ma'am. And for the diagnosis of another conditions like CML, CLL and hairy cell leukemia, then I will also go for the same bone marrow aspiration and biopsy, ma'am.
Okay, what is the normal erythroid myeloid ratio?
2 to 3:1, ma'am.
Okay, if you are planning for splenectomy, what are the vaccinations you will consider for this patient?
Vaccinations, I will consider first influenza. All the vaccines should be given 2 weeks prior to the elective splenectomy, ma'am. First pneumococcal vaccination, conjugated vaccine should be given and it should be repeated every 5 years. Influenza vaccine should be given every yearly. Haemophilus influenza B and meningococcal vaccine B and C strain should be given to the patient, ma'am. Because after splenectomy there is more chance of sepsis from the encapsulated organisms, ma'am.
Encapsulated organism.
Organisms, ma'am.
Okay. Then other investigations?
Then another investigation is colonoscopy, ma'am.
Why colonoscopy?
Patient is having anemic symptoms, ma'am, with the paler symptoms. So I also want to check for any lower GI malignancies, which causes the there any primary malignancies which are hidden in the lower GI, ma'am.
What malignancy you are searching for?
Ma'am, lower GI malignancy below the transverse colon, ma'am. Any rectal carcinomas, rectal malignancies, which
No, the
will
patient is not. No, you didn't tell that the patient is having any bleeding PR.
no, ma'am, no
He's
bleeding
having
PR, no
only EC
Farina, ma'am.
fatiguity. Then why do you want to do colonoscopy in this patient? You are suspecting any colonic malignancy. Yeah? What colonic malignancy will have huge spleen like this? Is the patient having upper GI bleed?
No, ma'am.
Do you want to do upper GI scopy?
No, ma'am.
Don't want to do upper GI scopy. Only colonoscopy.
Yes, ma'am.
Okay. You have, for this case, with massive splenomegaly, when you suspect EHPVO, we can do
Okay, ma'am.
upper GI scopy to rule out esophageal varices.
Very
Such
good.
huge spleen, I don't think so. You want to rule out any lower GI malignancy with no lower GI symptoms.
Okay, ma'am.
Okay.
Okay.
Yeah. Continue, Srinivasan.
Slides over, ma'am. Then.
Okay. What are the other investigations you want to go?
Ma'am, if the bone marrow aspiration and biopsy confirms the malignancies like non-Hodgkin's lymphoma, I would further go for flow cytometry, ma'am.
Okay.
Flow cytometry. Then the other investigations will be stool occult blood. I will send this for this patient, ma'am. Patient is having anemia, ma'am. No bleeding PR, no history of melena. So I would also check for any GI loss of bleed, which causes the which is the cause for anemia, ma'am.
Okay. Okay, sir.
I think this will do, madam. He has answered
Okay.
most of the questions.
Yes, sir. Very good.
Yes, madam.
Yeah. Thank you, madam. Thank you for
Thank you, sir.
detailing about the approach to patient with the spleen, especially different aspects of combinations of clinical profile of the patients. And I think really appreciate Srinivasan for answering in detail about the understand the depth of information what he has understood during this learning process. Really
Thank you,
appreciate
sir.
Srinivasan. Yeah, really good. And
Thank
you're
you,
also
sir.
able to answer specific the pathological microscopic findings also, which tells you that you have got some sort of clear idea about understanding of the depth of information. And Shivkumar, anything else you want to add, sir?
Yeah, I think we are done, sir.
Yeah. Really, thank you, Dr. Shivkumar, sir, for wonderfully moderating this and being a faculty for this evening. I also thank Dr. Nambirajan, sir, and Dr. Sendilvadi Madam for being the faculties and did take the discussion very nicely and made the postgraduates benefit out of this discussion. I appreciate both Dr. Yashoda as well as Srinivasan for wonderful presentation and answering the questions in appropriate manner. And all the best to both of you, and thank you, every one of you, and good night to all of you. Good night.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, ma'am.
Yes, sir. Thank you.
Thank you, ma'am.